be conducting the birthing video now on our newborn again. So this is going to replicate the, indicate the vagina. So this is going to be our dilation, only because I can't really find any other resources to try and do this. So we're all suited up. Our patient, we haven't really got a mother, but we're going to pretend that this is just what we're going to be able to see. So the mother's having the baby will be coming out this way. And as the baby comes out, we're going to see just the top of the head like this. The baby's going to be pushed out until it comes out about like this positioning. Once we get to here and we see the head out, we're going to support the head. Support the head like this. The baby will then rotate to the way that it feels most comfortable to try and get the shoulders out. Once the baby's turned to a position to get the shoulders out, a side will pop out. So we'll say this shoulder's popped out, like this. And then we're just going to support the head. We're not going to do it's a hands-off approach. So I'm holding the baby, as you can see, but that's not how it's going to happen. So now that we're just supporting the head, now both shoulders have popped out. And then with one more gentle push, the baby is going to fall straight out of the mother, and all we're going to do is just be there to support the baby's neck and body. Once the baby is then born, we're going to place it straight on the mum for that skin-to-skin contact, leaving the umbilical cord attached as she still hasn't given birth to the placenta yet. So it's allowing for that umbilical cord to give the baby the full volume of blood. While the mother has delivered the baby, we're going to be doing the first Apgar scale, which happens just the minute after the first baby's born. Determining from when the baby's born and what the Apgar scale is will determine whether we make any interventions or not. Sometimes all it takes is a bit of a rub of the belly and a rub of the back just to try and stimulate their first breathing and first crying. Once that happens, we're going to allow 15 minutes around for the mother to birth the placenta, as the umbilical cord is still attached to the mother, like through the placenta and through the vaginas, which is fine. So we're going to clamp the cord for the baby around the 15 and 20 centimetres, and we'll detach that if need be. If not, we can birth the placenta and then we do it afterwards. So we can give the mother a shot of oxytocin to try and get that process happening. Sometimes they can refuse that, which is fine, which they can do, but if they do, we'll give them a shot of that to try and help them stimulate that. And then we're just going to do the same thing, just catch that. We're not going to pull it, just wait for it to all come out on its own, and at that time we'll transport them both to hospital just to make sure everything's going to be fine. If not, we can wait for our backup team to come, because we'll need 2 ambulances really to try and help us, because now we have 2 patients. And that's it. It's a bit of a quick video, but as you said, it just comes out. We're going to do a hands-off approach. We're just literally there to catch the baby. They'll rotate themselves. The umbilical cord's nothing to worry about because it's long enough. And that's how it goes. Thanks.